Ahmed Almustafa, who is a fellowship program director, a physician of heart failure and transplant cardiology from King Faisal Specialist Hospital and Research Center, Saudi Arabia.
Good afternoon, everyone. Thank you to the organizer for inviting me to participate in this meeting. I have no disclosure. I had the privilege to do my Advanced Heart Failure Fellowship here at UT Houston, so it's always good to be back here in Houston. In the middle picture, this is me with my co-fellow Priyanka. As you see, we are smiling, and the reason for that, because Dr. Nathan was finishing his rounds before 7 p.m., or by 7 p.m. So when Dr. Jumian tasked me with this talk, I started researching about cardiogenic shock, clinical data, outcomes, registries in Saudi Arabia. So I realized that we have a big or significant gap in data collection registries in regard to this field. All what I find is two publications from two single centers, around 120 patients in each study. The primary treatment was an AMI patient, PCI, then inotroppressors. The utilization of MCS was very low and was mainly intra-aortic balloon pump. Not surprisingly, they both have high in-hospital mortality, actually reaching up to 85% in one of them. And I believe that this is the general theme in treating and managing cardiogenic shock in most of centers in Saudi Arabia for multiple reasons. One, as we discussed this morning and yesterday, that we all have negative trials in cardiogenic shock. And then also there's no clear evidence from either AHA, ACC, or the European regarding management of cardiogenic shock. If you look at this table, there's only one class 1 recommendation, and this is use of inotropes and pressors. So I decided, because I'm not going to spend the next 5 minutes just talking about, what like pressors, inotropes, and missing what are we doing in there now and the changes that happening. So I decided to change the topic from the Saudi experience to the Saudi journey. And sorry for doing this, Dr. Jumian, but I think I deserve it for the consents that I did, the sheet I removed, and the intimidating that I received during my fellowship. So I'll be talking about challenges that we faced, how we overcome these challenges, and what are we doing right now. Just to give you an idea about Saudi Arabia, it's around 830,000 square miles. It's the largest country in the Middle East, 13th largest country in the world. It's a quarter to the size of the United States. Currently, we are 34 million people. This is expected to go up by 2030 to 42 million. I work at King Faisal Specialist Hospital, one of the biggest centers in the Middle East. It's located in Riyadh, the capital of Saudi Arabia. We receive patients from all corners of Saudi Arabia. We have 1,000 bed capacity. We do multiple organ transplants from heart, lung, liver, kidney, pancreas, bone marrow, and intestines. We have very active oncology center as well. Our advanced program was established in 1989. Up to date, we did around 460 transplants. We did around 165 VADs. We launched our CardioMEMS program a year and a half ago, and up to date, we did 90 cases. So the challenges we face that we have high volume of referrals. Patients, influx from all regions of Saudi Arabia, and we have to accommodate that. Difficulty in timely transportation these patients. Patients coming from north or south, they spend more than like 2 or 3 hours flight. Also, bed availability. We are also busy center doing cabbages, valve intervention, structural arrhythmia, congenital heart disease. So it's not only like cardiogenic shock patients. We did also, 2 years ago, we didn't have any protocols about managing these patients. And late recognition and management of cardiogenic shock from referring centers and from internally at our center. And we do limited numbers of donors. So these patients spend a lot of time on acute MCS. So how we overcome these challenges? We formed a shock team. We established a heart failure unit that just opened 2 weeks ago, and we developed shock protocols. We network with local hospitals in Riyadh. We went there on-site visit, talked to them about cardiogenic shock, early recognition and early transfers. And we increase implantation of cardiomems and for our ambulatory patient for early detection forcing of hemodynamics. And this has been helping us a lot, especially as we receive patients from all the kingdom. And we increase the utilization of MCS at our centers. 2 years ago, we did not do a lot of MPLS as well. And we increased the pool of donors by utilizing transmedics technology. What I observe in our patients in the last 2 years that I spent in Saudi Arabia, we have a lot of young patients, non-ischemic cardiomyopathy. I'm seeing a lot of them, most likely because there is a lot of marriage between relatives. So I see a lot of LV non-compaction, ARVC, familial dilated cardiomyopathy. These patients always present with some kind of valvular pathologies, where I see a lot of myocarditis, also good amount of post-cardiotomy shock because we do high-risk surgeries, and we do a lot of redo sternotomy as well. So last year, we did around 17 VADs in adult, and we did 18 transplant. And if you look to our RVAD, post-LVAD, 60 of our patients require RVAD. And this is one of the reasons for that, that also, okay, they have a not good RV, but they present very late when, when intervention is our intermax patients is like 1 or 2. This is our cardiogenic shock protocol. I'm just going to go through some cases that we did in the last 2 years. This is a 23-year-old male who presented with cardiogenic shock. His lactate was 5. As you can see in his echo, he's severe biventricular failure. He has severe biatrial enlargement. After diuresis, he went for right heart cath. His mean PA pressure was 73, out of proportion to his cardiomyopathy. His PA sat was 40. His cardiac index was 1.4. His PVR was 19. After we have a multidisciplinary team, and patient went for heart and lung transplant. This is 1 year post, transplant, and he's doing good. This is another patient, 20-year-old male, dilated cardiomyopathy. He presented to our ER with a shock stage E. He was placed in VA ECMO due to severe biventricular failure. He went for HeartMate 6 for 1.5 years, and he had a transplant 3 months ago, and he's doing great. This is another patient, 18-year-old, presented with cardiogenic shock, dilated cardiomyopathy, severe MR, severe TR, RV is moderately to severely reduced. His wedge pressure was 31, mean RA was 13, cardiac index 1.4. We stabilized him with CP Impella, which was not there 2 years ago. And now we're doing this because his axillary artery was a small 4.55, and then he's the one on the left, the 18 years old, and he went for HeartMate 3, and he's doing good. And actually, he is the one who helped us with the patient, the 16 years, to convince him to go for, HeartMate 3. He had similar presentation as well. These are 3 patients also presented with cardiogenic shock with elevated lactate. Liver function was worse, and they underwent 5.5 and stabilized them, and then they went for HeartMate. So what are we doing? What's our goals is helping more patients, supporting other centers to appropriately implant MCS early to stabilize patients before transfer, establishing registries, and pursuing better outcome. And with that, I thank you very much.
So Ahmed, that was fascinating.